All right, so now we're going to talk a little bit about predicting preterm labor and preterm delivery, and then managing preterm labor. So we would kind of assume that preterm labor typically leads to preterm delivery without intervention. The reality is that we don't seem to have a very big impact on whether someone is going to deliver or not, or deliver early or not. There are some interventions to prevent preterm delivery, but most of them really are not much more effective than placebo. So the real test is figuring out which patient who's having preterm labor is likely to deliver early. So you need to, it's weird, but we need to kind of separate preterm labor from preterm delivery a little bit. So there are some tests that are done to give us an idea, or to give the provider an idea how likely the patient is who is in preterm labor, how likely that patient is to deliver early. So one is fetal fibronectin. This is a substance that's normally found in cervical and vaginal secretions early in pregnancy. It disappears and it comes back in late pregnancy. The test is by vaginal swab. If it's positive, about 25% of the time that patient will go on and deliver within the next couple of weeks, okay, within the next 2 weeks. So it's not super predictive positive, but if it's negative, that patient is unlikely to deliver within the next 2 weeks. So if we have a patient who's having preterm contractions, they did a fetal fibronectin and it's negative, they're unlikely to deliver within the next 2 weeks, okay? If it's positive, there's like a 25% chance they're going to. So negative is more sure than positive. They also can do an ultrasound to measure cervical length. Cervical length, sometimes the cervix begins to thin early. Okay, so they measure the length by ultrasound. And sometimes think of the cervix like a tube. It has an external os, that's the opening on the outside in the vagina, and it has an internal os. Let's see if I have a straw. I'm going to pretend this syringe. Okay, we'll get a syringe barrel here. If this is our cervix, it's a very, very long cervix. This is our cervix. This is the uterus. Okay, so this opening is the internal os. At the bottom, this opening is the external os that opens into the vagina. So when the cervix thins, those kind of come together and it all dilates. But sometimes it'll start opening on the inside or on the outside first. The inside may be opening and the outside closed, or the outside opening and the inside closed. So that have blue food coloring in it, so I have blue all over me. So if it's opening on the inside part first, that's called funneling, and you can't really tell it from the outside. On an exam, they would still feel closed because the external os is closed. But if they're seeing funneling, or if the cervical length is getting shorter, that can indicate possible preterm birth. Okay, it's again not very predictive, but if the cervical length is greater than 30 millimeters, then they're unlikely to give birth prematurely. So if they combine fetal fibronectin and ultrasound measurement of the cervix, then they can get even better at predicting. We're still better at predicting who's not likely to deliver than at who is likely to deliver, but that can be helpful in determining how aggressive to be with intervention. So think about predicting preterm birth. Remember that not all preterm labors are going to lead to preterm birth. So let's talk now about managing preterm labor. And number one is prevention. And I just said that it's very hard to prevent preterm birth. But if we can identify and address risk factors for preterm labor before pregnancy or early in pregnancy, we can get that patient as healthy as possible before pregnancy. We can encourage them and help them to stop smoking. Those things decrease the risk of preterm labor. Some patients who have cervical shortening have shown less risk of preterm delivery if they use a progesterone gel. So prophylactic progesterone has been effective for some people if the cervix is shortening early. So the major thing is early recognition. And the idea is we want to recognize early that this patient's in preterm labor. We want to have some idea how likely she is to deliver. And then there are things that we can do. We're not very good at preventing that preterm birth, but we can maybe delay it by a few days. And there's some things we can do to accelerate fetal lung development. So early recognition, we would like every person to get prenatal care, everyone who's pregnant to get prenatal care. And there are a lot of women who don't have access to consistent prenatal care in the US. We want to teach pregnant women the symptoms of prenatal or preterm labor. So what does preterm labor feel like? The contractions of preterm labor may not feel the same as full-term labor. So if they've had a baby before, they may not be expecting, they may not be recognizing those signs of preterm labor. Contractions that happen more frequently than every 10 minutes and they last an hour. Before 37 weeks, if they're regular contractions more than every 10 minutes lasting an hour, that can be a sign of preterm labor. Those contractions may not hurt. They may just feel like tightening. Sometimes patients will say it feels like the baby is balling up. Sometimes it's felt as pressure on the bladder. I've had patients who come in and they've noticed that they have to go urinate, but it's like every 5 minutes, and you can set a watch. You can look at the watch and know it's coming. That's the pressure of the contraction on the bladder. And that may be what they feel from the contraction, because remember, the uterus is not as big, it's smaller. Low abdominal cramping and diarrhea is something needs to be, we need to check out, we need to watch for. Dull, intermittent, low back pain. Again, well, I have a backache, but that backache seems to come and go every 6 or 7 minutes, or every 3 to 5 minutes. That backache may be where they feel the contractions. Suprapubic pain or pressure, pelvic pressure or heaviness. Sometimes with the contraction, they'll feel like the baby is pushing down. Urinary frequency, an increase or change in the amount of and character of vaginal discharge, ruptured membranes. Okay. So the goal of early recognition is not that we're going to stop all of the preterm births, it's that it allows us to care for them better. We want that patient who is at risk for preterm delivery to be transferred to a hospital that's equipped to care for a preterm infant. We would preferably that happens before delivery, because we can fly out a baby that's preterm, premature baby. That happens all the time. But if we can send that mom to a hospital and have them deliver in that location that's equipped to care for the premature baby, the outcomes tend to be better. It is safer. It's always safer to transport the baby inside the mom if that's possible. Because they're preterm, we won't know beta strep status, and this baby's going to be at greater risk, so they're probably going to get prophylactic antibiotics. If it's a possibility they might deliver, they're going to get prophylactic antibiotics to prevent GBS sepsis. We can give glucocorticoids to accelerate fetal lung maturity, and we're going to talk about that more a little bit later. But one of the ideas of identifying early is so we can get some steroids in, because that accelerates lung maturity and improves outcomes. If it's earlier than 32 weeks, then giving mag sulfate actually decreases the risk of cerebral palsy in the infant. So mag sulfate would be given if they're likely to deliver before 32 weeks. So the one other piece of management I want to talk about is sometimes people in preterm labor are advised with some lifestyle things. They're often advised to go on bed rest. There's no evidence that it prevents preterm delivery. Bed rest also has a lot of adverse effects. But also, if someone is in preterm labor and you tell them, well, you don't have to be on bed rest, and then they deliver, there's some potential liability. Bed rest is not really evidence-based, but you still see it advised a lot. If one of the things that we can fix, if they're in preterm labor because of dehydration, hydrating them can sometimes stop can sometimes stop those contractions. And sometimes dehydration can trigger preterm delivery. So that's one of the times that we might be able to actually prevent a preterm delivery. Another time that we might be able to effectively do that is when the preterm contractions or preterm labor are caused by an infection. One common cause of that is a kidney infection, pyelonephritis. If we can treat the pyelonephritis, sometimes we can prevent that delivery. Patients who are in preterm labor are advised to restrict sexual activity, and that's both pelvic rest, nothing in the vagina, but we also don't want sexual stimulation, and that's because oxytocin, triggered by sexual stimulation, causes more uterine contractions. There's not really a lot of research whether or not that's effective. That's recommended based on theory, but we don't know if it tends to increase the risk of delivery or not. So we advise no sexual activity until they're at least full term or near enough full term. Home care, we want to have them resting. We do want decreased activity, not necessarily bed rest, but also a lot of times moms who are in preterm labor they have other kids, they may have work, they may feel like, or they may not be able to afford to be off work. So there are a lot of barriers to that kind of rest and relaxation that we want them to do. Aside from just the boredom of not being able to do a whole lot. We used to do a lot of home monitoring. I'm not seeing as much reference to that lately, but fetal monitors are available for home use, and they're sometimes used to monitor contractions in preterm labor. Okay, the next section, we're going to talk about some medications that stop contractions called tocolytics.